Good morning and good afternoon if you're on the East Coast or somewhere in a different time zone. My name is Trey Reckling, and I'm the founder and director of Academy of Cannabis Science, and I am pleased to be moderating our HIV and cannabis past, present, and future panel today. So thank you for joining us. You will be able to ask questions today by submitting the questions in the chat. The speakers may answer in real time, or they might choose to save it for the end. We will have definitely save time for Q&A at the end. So let's get started. We'd like to welcome our two speakers today, Dr. Justin Knox and Dr. Jennifer Manuzak. And Dr. Manuzak, you're gonna have to correct me on the spelling of your name. If you don't, let's start with you. Dr. Manuzak is an assistant professor at Tulane National Primate Research Center in the Division of Immunology, and Dr. Justin Knox is an assistant professor at Columbia University. But I'm going to ask them to take a couple minutes and do their bios better justice than that, because we know it's a lot deeper than just that. So, Jennifer, if you could start us off, that would be great.
Sure. My name is Jen Manuzak. Like you just said, I'm an assistant professor at Tulane and specifically the Tulane National Primate Research Center. I wear two science hats, as I like to say. My first science hat is using the non-human primate model to look at the impact of malaria and SIV on pregnancy and mucosal immunology. So we look at co-infections. And then my other science hat is to look at the impact of substance use, particularly cannabis, on immunity in people living with HIV.
Fantastic. Thank you very much. Dr. Knox or Justin, how are you? Could you tell us a little bit more about you?
Sure. Yeah. Thanks. Thanks for organizing this and inviting me. So I am also an assistant professor. I'm based at Columbia University in New York City. I'm an epidemiologist by training. Most of my research also focuses on HIV and includes some focus on substance use as well. It's mostly actually been alcohol use, but more recently cannabis use as well, with a large focus on racial and sexual minority groups, and it includes both domestic and global work. So I did most of my training in New York City. I did my postdoc, my PhD, my master's in public health, all there. But previously I'd done a master's degree in medical anthropology at University College London. And I also spent some time in sub-Saharan Africa in the Peace Corps in what's called Eswatini now, which was Swaziland at the time. So yeah, that's my background.
Fantastic. Thank you both very much. Dr. Manuzak, if I could start with you, could you tell us a little bit more about your research? We know you could get real heady here and leave us in the dust, both of you, but could you help us? You talked about co-infections and how that affects a person's health, but could you break that down for us a little bit more?
Sure. So the co-infections are really interesting because the areas that HIV is endemic in actually have a lot of geographical overlap with where other diseases are endemic. So in the context, for example, of places like sub-Saharan Africa, you can also have high levels of malaria infection. And so that's where we really got interested in that work, because we wanted to know if you have both infections at the same time, is that going to affect your ability to either fight off HIV or maintain your levels if you're on antiretroviral therapy, or would it affect your acquisition rates? There is evidence out there that if you have had exposure to malaria in the past, you may or may not have a higher risk of getting HIV if you were exposed to that. And so some of my earliest work in that was using the non-human primate model to look to see whether or not exposure to malaria infection would decrease HIV vaccine efficacy. And we have some evidence to show that that might be the case. And so that's really important, because if we can figure out how and why that's happening, we can make better vaccines that could protect people from HIV if they had been exposed to malaria previously, which is common in areas like sub-Saharan Africa. We just got funded to look at whether or not getting malaria in pregnancy in women with HIV can drive morbidities and mortalities, because there's very strong evidence that getting malaria while one is pregnant is a huge driver of morbidity and mortality, and it's likely to be even more so when you're also infected with HIV. So if we can figure out the molecular mechanisms behind that, we can make better therapeutics and interventions to help people not to experience those morbidities and mortality.
Fascinating. So does that also, if a person has HIV, does it prevent them from taking some of the precautionary medicine or some of the medicine that could prevent or reduce your risk of getting malaria?
Not necessarily. So there have been some studies to look at drug-drug interactions, and there is some evidence that if you are taking a certain kind of antiretroviral therapy, you may not want to take some malaria prophylactic drugs.
Mm-hmm.
But in general, there aren't too many overlaps. And yes, if say you were a person with HIV and you were traveling to a malaria endemic area, you may not want to be on certain antiretrovirals if you're also taking malaria prophylactics, but your doctor would be able to advise you on the best combination in order to make sure that you're, doing the right thing when you travel, for example.
Okay, great. Thank you. Dr. Knox, could you talk to us a little bit about the research that you're working on as well?
Sure. Yeah, I'd be happy to. Unlike Jen, I only do, research with people. No cool primate stuff. But yeah, so the focus of my work, or since I was a Peace Corps, has kind of been focused on HIV and trying to understand what's putting certain people at increased risk of getting infected with HIV, of engaging in the standard HIV prevention behaviors, such as getting tested, regular testing. Traditionally, especially in African settings, it was condomless anal intercourse, but it's come to include PrEP more and more in that setting, as well as in the US. And then now that from when I started my work in Africa, that was before the wide scale rollout of antiretroviral therapy. But now HIV, highly effective HIV treatments are available. So more and more my work has been about trying to understand what allows people to get linked to care, to stay engaged in care, to get on antiretroviral therapy, to be adherent to it and become virally suppressed, which has great implications for the epidemic generally, because we know now that, from the evidence that if you're unsuppressed, you're unlikely, you're unable to transmit onward to others, so big implications for ending the HIV epidemic. So sort of my research sort of sits in that context right now. And, as my training, some of my mentors have had a large focus on substance use, I sort of bring that component into my research. As I mentioned, a lot of it's been focused on alcohol use and drinking, and looking at some of the health benefits of drinking reductions, even non-abstinent drinking reductions. But it's also, more recently, included cannabis use as well as stimulant use, and thinking about how certain substances might be driving the disparities that we see in HIV infection, particularly in the US, where you have, particularly Black sexual minority men, at such increased risk of HIV infection. Current estimates are that 1 in 2 Black sexual minority men living in the US will get infected with HIV during their lifetime. So really high rates, and just trying to understand what might be contributing to that, and then in turn what we might be able to do to address that and to improve that. So we've seen fairly high levels of cannabis use in Black sexual minority men. So there's some question at the moment if that might have an impact potentially on whether or not they're engaging in HIV prevention behaviors optimally, with the introduction of technologies such as HIV pre-exposure prophylaxis, or PrEP. We've actually seen those tools that actually have the ability to sort of narrow, gaps in HIV incident and HIV burden, actually widen those, because the people who need those technologies the most don't get them or have barriers to access them and adhering to them. So we want to, kind of leave no stone unturned in that sense, and look and explore, what could be contributing to that, and what could we do to help support, men like that, to prevent them from getting infected with HIV, as well as to help them achieve, optimal HIV care outcomes.
Thank you both for the work that you're doing. We know these are deep dives, and there's so much to learn. And then we've come so far, to even be able to be at this point. Dr. Manuzak, am I saying that correctly?
It's Manuzak, yeah. It's
Manuzak, sorry.
Exactly the way that it's spelled.
Okay, great. Makes it easy. Could you tell us a little bit about why this field of research? What drew you to studying what you study?
So I've always been interested in HIV infection because I think it's a really, fascinating virus from a scientific perspective. It attacks the immune system itself, which was just so cool to me when I started graduate school and decided to stay in this field when I finished my PhD, just because I think that the work is so important and so very interesting. And it's been 40 years, over almost exactly 40 years since HIV was first discovered. And we learned about this virus and the effect that it was having on very vulnerable communities. And we still have so much to learn from it. And so there's that perspective, but also the fact that it's just, again, from a scientific perspective, a really good model for chronic inflammation. And that affects so many other issues and other conditions and everything. And so if we can understand the molecular mechanisms and the immune mechanisms that are leading to chronic inflammation and how to better fight against them, we could apply those findings to a variety of different conditions, which will all at the end benefit human health.
Fantastic. Cool. Thank you. And Dr. Knox, you mentioned the Peace Corps. Could you talk to us a little bit about that, your involvement, and how that led you to doing what you're doing now?
Yeah, sure. Thanks. I mean, I remember as growing up, learning about HIV and hearing about HIV and, kind of hearing about it in the news and not knowing much about it, and then learning that, there was such a huge impact in sub-Saharan Africa, and how, HIV, was more prevalent than anybody, had expected in a general population setting in a lot of sub-Saharan African countries. So I was sort of aware of it, but, growing up, being a normal youth, doing my thing. And then I, as an undergraduate student, I was interested in foreign languages. I was interested in anthropology and learning about other cultures. And, I ended up majoring in it. I ended up studying abroad in South America and had a great experience and really enjoyed, that experience of, being in a foreign setting and learning a new language and engaging with people, outside of a more, touristed setting or way of interacting. So when I finished college, I signed up to do the Peace Corps, to get more of that. And I was interested in anthropology and I was interested in health. And they said, where there's the greatest need right now is sub-Saharan Africa. They've actually ended a lot of Peace Corps programs there because things were generally improving. But then with the HIV crisis, that a lot of them were re-implemented. And so I kind of signed up and they pick a place and I was like, wow, Swaziland. I didn't even really know exactly where it was on the map, even though I was fairly, aware of geography and stuff. So I went there with a group of other, maybe a little naive, but, altruistic, college age, young adults and started, kind of orienting ourselves to the situation. And it was actually pretty grim at that point, because at that point, HIV was really a death sentence. There was just palliative care. There was no antiretroviral therapy, what had been developed in the US. There were questions about whether or not we should make it available, widely available in African settings, and if that would lead to, antiretroviral resistance, and that was a big battle, much like I imagine we're seeing today with COVID vaccinations, and what obligation do we have as, in the developing world to make vaccines available and to, think about these health problems globally. So yeah, that and ever since that experience, having sort of seen firsthand, how devastating, impactful, HIV could be, I sort of have spent my career, researching it, but I needed more training at that point. I just had my bachelor's degree at that time. As I mentioned, I was interested in anthropology, so I was kind of first doing things from an anthropological perspective and spending time having conversations with traditional healers and trying to learn about local conceptions of HIV and disease and how this fit into their frameworks. But ultimately, I felt like I wanted to do something a little more practical and applied. And that led me to, public health and to epidemiology. And, I brought up COVID before, but again, I think there's so much more awareness now of what epidemiology is and what public health is and how important it is, living through this pandemic. So, hopefully, there's increased awareness and priority to work on these health issues and to engage experts and to, think about these, problems holistically so that we can, optimize our efforts.
For sure. COVID has been an education for so many of us, right? Just to have some of the basic terminology when it comes to viruses and that sort of thing, and understanding some of those differences. Dr. Manuzak, could you talk to us a little bit about your current research? We know research can last years. And so kind of tell us about the runway you're on now, about how long will the current study take, and what do you see in the horizon? Do you have anything kind of next on the burner that you're excited about, or are you just too busy working on what you got going now to think about the future?
Both, but there's always so much cool science that we can do, right? Actually, Justin and I are working together on some really cool projects, and we have a lot of projects that we're trying to put together and get some funding to do. So one of the main things that I think would be of most interest to this audience would be the paper that Justin and I are writing together right now, looking at following up on some work that we did with the ACTG. We used records from the HALO cohort, which is a long-term follow-up study of older people, and they defined older as people older than 40. And they followed them long-term in an observational study. And so we used those records to try to look at the impact of regular cannabis use on ART adherence among people with HIV. And what we found was that people that reported regular cannabis use actually had decreased adherence to their antiretroviral therapy regimen. And so that's really important because, as we know, adherence and proper adherence and consistent adherence to antiretroviral therapy is really, really important to maintain HIV, and it allows people with HIV to live longer, healthier lives and decrease risk of morbidity and mortality. And so if someone is using cannabis regularly, the next steps are to figure out what it is about regular cannabis use that is causing the lack of adherence or potential lack of adherence to their drug regimen. And so Justin and I are considering ways that we can follow up on that work. There were several caveats to that study. We were using self-reported cannabis use and self-reported ART adherence. And so we want to go back to the actual samples that were collected as part of that study and see if we can request biological specimens so that we can measure actual levels of cannabis, so that we can really determine what the level is that one would reach in order to cause that link with ART adherence. Because some of our previous work had suggested that actually cannabis is providing a beneficial effect where it's decreasing inflammation. So my suspicion is that it's sort of like, a bell curve where, it's good, it's good, it's good. And then too much of a good thing is also a bad thing. And so if you can find that level of cannabis usage and ART adherence, and maybe we can investigate some other ways to achieve both, then we can find that sweet spot essentially. And so the way that I think of Justin and I, the work that we do together is like I'm the lab person. I do the the lab science, and Justin helps me to put a lot of that into context for the epidemiology and public health perspective. So, because I often, that's not my my strong suit, but Justin's clearly an expert in that area.
Well, and that's interesting because, like you said, originally I think a lot of the excitement was that cannabis was helping people maintain their antiretroviral therapies because it was helping offset some of the negative side effects, right?
Absolutely. So, I mean, cannabis use is, at least what people have been reporting it for can often alleviate those side effects of art usage. And so, yes, I think it's still, definitely a good thing. We have so much more work to do, though, because, if we can figure out what it is in the cannabis usage, because there's so many components. Like if you break down cannabis to its actual molecular structures and the metabolites that are your body is being exposed to when you consume cannabis, if we can find the exact right one, there's the possibility for potentially making non-psychoactive cannabis derivatives that could be used in the context of other drug regimens. And so there's a lot of work there to tease apart exactly what's happening so that we can make the best kinds of formulate the best approach to having those beneficial effects of cannabis usage while still maintaining all of the other drug regimens. And I see Michael put in something here about in the chat about long-acting injectable treatment. Absolutely. So if we can find better art regimens, could we combine that with ways to take advantage of also the beneficial immunological effects of cannabis usage?
And when we know a lot of patients don't understand about the biphasic curve for cannabis, and too much doesn't necessarily, or more doesn't necessarily mean better. And so it's part of patient education is too, as well, I imagine. Dr. Knox, you talked about prophylactic type medicine. And so could you talk to us a little bit about your takes on the data when it comes to cannabis use and PrEP?
Yeah, sure. I'm happy to talk about that. I do want to say just a quick disclaimer, like, a lot of this is emerging, right? Like, ART, treatment for HIV medication has been around longer. So I think there's been more research in that area in terms of cannabis use and medication for HIV, people living with HIV. But, as PrEP is an emerging tool, right, that we have available, there's some interest is what are some of the relationships that we've seen with cannabis use and ART similar, but there's different dynamics, right? Like as Jen mentioned, like people might be using, cannabis for medical reasons, right? If they're living with HIV, and in certain in situations, it's like medically indicated for that, right? And others not, but then people might be using, cannabis to medicate for other reasons, even if they're not living with HIV, just at risk for HIV. So it's emerging. And, I did sort of read up on this literature recently for a grant proposal that Jen mentioned, but I imagine there's things that have come out even since that went in, a year or so ago. But at that time, there was kind of, I found maybe 4 studies, and there was kind of conflicting evidence. I think one found an association, one didn't, and the other, there was like not a direct association, but there was other factors, other contextual factors that possibly possibly explained why there wasn't a direct effect. And in summary, I think what it probably is there's a lot of nuance, right? When we say PrEP, are we talking about starting PrEP? Are we talking about staying adherent to PrEP? Are we talking about maybe discontinuing PrEP after being on it for a few months? And also what levels of cannabis use are we talking about, right? Like, are we talking about just casual users or heavy users, daily users? So I think there's so much more research that could be done on that topic. And hopefully because of our grant, Jen and I will be able to do some of that research, and a lot of, our research, we're going to be doing it among a cohort of Black sexual minority men who are living in Chicago. And I think what I'm talking about, I can't remember how I reviewed it, but I think most of these studies were done among sexual and minority men. So outside of that context, I would have less that I could say about that. But that seemed how I seem to remember the literature. But interesting, I just actually I've been involved in 2 studies. So we have a paper that's just coming out. Like I just got an email this morning that it's available online. And we found that this is a cohort of Black sexual minority men and transgender women living in Atlanta, Georgia. And this was data collected from 2012 to 2014, right? Because it always takes some time to analyze the data and clean it and then write it up and disseminate it and then get it to review. And that, like, it all takes months and stuff. But we found that the Black sexual minority men and transgender women who reported daily cannabis use were 3 times more likely to seroconvert for HIV by the end of this 1-year follow-up than those who reported, any non-daily use. So it could have been, weekly, or it could have been not at all. And that relationship wasn't explained by the other sexual behaviors that we asked them about, like, how many sexual partners have you had in the past 3 months? Have you had, unprotected anal intercourse? But this was also before PrEP was really widely available, right? So one thing that we'd love to know is, like, does this relationship hold now that, HIV prevention, pre-exposure prophylaxis is available, and also maybe could there be some biological vulnerability, like the work that Jen does and is describing. So that's an exciting finding that, we're kind of curious to know what's going on there. We don't necessarily think that, there's a direct link, but maybe, cannabis use is associated with something else that's driving this, or maybe within this population, there's, it's particularly, putting them at risk for HIV seroconversion. And then the other study was also with Black sexual minority men living in Atlanta, Georgia. But we took Black sexual minority men living with HIV and white sexual minority men living with HIV. And we looked at what the differences were and how many were virally suppressed. And if you were Black sexual minority men, you were 60% more likely not to be virally suppressed. And then we controlled for a bunch of other factors to see what could we reduce this disparity by taking into account these other differences, right? Like the Black sexual minority men were younger, right? And when you control for that reduces the disparity, right? Because younger people are less likely to be virally suppressed. And then we also controlled for a bunch of structural factors like, income and housing stability and insurance, access to insurance. And those all, reduce the disparity by a little bit. And then finally, cannabis use also reduced the disparity by 5%. So we were wondering, why would cannabis use potentially be driving a disparity between Black and white sexual minority men so that they're not doing as well, in terms of their HIV care outcomes. So those are 2, all science, like, as you'll hear, like, we don't want to say there's definitive things. Everything needs further research. We need to dig into this, like, what's happening here. We don't know if, the cannabis use preceded the HIV care outcomes, or if they're because they're virally suppressed and they're using, cannabis to self-medicate, so there's so much work to be explored in the area. I do think it's a really, emerging field and lots of great work to do. And I think we want to do it in the context where, we realize that, like, there's a changing legal landscape for cannabis, right? It's being legalized for both medical and recreational use. It's been over policed and there's been so much harm from previous policy. So can we still, acknowledge that there's a need for this change, but also say, like, well, let's be consider about what are the potential impacts this is having on HIV and putting, people who are at risk or vulnerable, increasing that vulnerability. So that's my take on it right now.
So for the uninitiated, seroconversion, you're talking about detectable levels of antibodies in the blood, or are you talking about the when you were saying it took 3 times longer?
I meant they went from being HIV negative to HIV positive. But from the beginning of the study, everyone was HIV negative, and at 12 months later, everyone tested again. And, of the 400 and I want to say 50, 5% seroconverted, right? So over a 1-year period, 20 or so people became HIV positive. And that's a very high level, right? Like you wouldn't want that high of a level in your population generally, right? Because these are high risk individuals, right? So that's why there's concern. We need to understand like what's driving these HIV infection rates.
Thank you. And kind of a general question to both of you. Most of us have not lived through a pandemic like COVID before, right? Some people remember SARS and some level of this, and we hear about Ebola outbreaks, but in a way that this has touched everybody's life. Has that sucked the air out of the room and limited or slowed the research money and availability or support you're getting when it comes to HIV/AIDS? And if that has drawn attention from the work that you're doing, how do we refocus that attention?
Justin, you want to go first or should I?
Yeah, well, you've been going first, so we'll keep the order.
Okay. I mean, I guess in my personal experience, sure, it obviously has taken all of our attention and it's impacted our work in ways that I think a lot of us wouldn't have expected. For me, especially, all of my work happens in a lab. And with lockdowns and all of that, if you can't go into the lab to do said research, then that sort of affects how you're doing it. But I think that throughout the pandemic, we've really been able to continue the work that we're doing. I think there's been some Herculean efforts on the parts of a lot of people that have allowed us to continue doing the work that we're doing. And yes, I think, other diseases and other conditions have maybe lost the spotlight. And so that means that, we need to refocus attention in those areas, but it's still important. COVID is obviously a really important thing to be paying attention to right now. And so, I mean, I guess in my opinion, it's the work will be done. And those of us that are invested in the work are going to continue to keep doing it no matter what.
Have there been any and once again to both of you, and you can decide who takes, have there been any interesting correlations between HIV and COVID? We know it takes a while to really make definitive statements, but have there been any data points that have been of interest to you, either of you?
I mean, I think that at first there was some question, right? Would people living with HIV be at increased vulnerability? They are immunocompromised. And, I think finding that out speaks to the challenges as, scientifically of answering a question like that, right? Like, because you would basically need, people living with HIV are also very different from people not living with HIV for a number of reasons that likely led to them being infected with HIV, right? So, and you need time to follow it up and see. And they also, but I think my understanding of the latest evidence is that they've managed to pool data across multiple sources, and they have seen, an increased risk of serious COVID or hospitalization or death from COVID among people living with HIV, but not at the levels of vulnerability that we see with like diabetes or some other, health conditions, because all of this, even if you see a relationship, a lot of it meant like how meaningful is this like clinically, and so, like I think certainly it's not meaningful enough that we feel like it should disrupt HIV care, and there's already so many challenges with, implementing HIV care and getting the people, living with HIV. We have safe and effective medications. The challenge is really getting them all to take it and, to have access to that medication and take it so that they can be virally suppressed, or for the people who are at risk of HIV to get, prescribed with PrEP and take it so that they can prevent HIV infection. So I still think that, should remain the priority, but I think, yeah, there's some increased vulnerability there that, probably, would mean that, getting vaccinated and doing like all the COVID impact mitigation strategies are probably, particularly important if you're living with HIV.
And I think, on that note too, the COVID landscape just changes so rapidly all the time that it's sometimes, even for those of us that are reading about it all the time from a scientific perspective, we have trouble keeping up. And the deluge of information about it is always just, there's so much. And so I think, it's tough to keep up with it. And the best thing that we can do is just get vaccinated and be safe, wear your mask, all of that for, particularly for people that are immunocompromised. And even if you are 100% always adherent to your medications, it's good to be aware of those things. Cause even from an immune perspective, it's hard to say what's going to happen next because COVID just keeps continually changing all the time.
And speaking of continually changing, and we know so much about COVID and our research, or what we know is speculative still. But what about ART therapy and COVID? Any indication that might affect your ability to get COVID, protect you in any way, or anything like that?
So to my knowledge, no, there hasn't been any evidence that currently available antiretroviral therapy drugs would protect you from getting COVID. I think the pharmacokinetics of the drugs just work differently for the two different viruses. I think there was some push early on in the beginning of the pandemic to see whether or not currently available ART drugs would help. And I don't think that there's been any evidence that has been shown. Okay.
And looks like Michael is self-admittedly part of your fan club, but has put some links, some interesting links in the chat if anybody's interested there. And so
well, I'm Michael's biggest fan, so it goes both ways.
That's cool. So speaking of that, and obviously he's following your research. How can other people be involved in the research you both are doing if maybe they can't do the research alongside of you, but how do they follow it? How do they support it, and et cetera?
So for me, actually, I'm trying to, my lab is newer, my independent lab is newer. And so actually I spent some time on Friday trying to figure out how to set up my lab's social media accounts. So stay tuned. I'll be starting those soon. Michael obviously knows how to get in touch with me, and Neil as well. Hopefully we'll have a lab website and lab social media to follow that. And, Michael is also very, very involved in spearheading a lot of the really wonderful HIV cohorts and studies in the Pacific Northwest Seattle area. And so he obviously would be the person to talk to if you were interested in getting involved in actual, participating in any research studies.
And Michael, I apologize. I misspoke your pronouns. I caught myself though. Thank you.
No worries. I'm going to change that to basically say that it can be he or they.
Oh, well, regardless, I just want to make sure. I want to correct myself. So to both of you, where do we go from here? I know there's probably no shortage of what you, given the time and resources, would like to study. But once again, on that horizon, if you could go anywhere with this that you want in the future, on down the road, what would that be?
Oh gosh. Justin, I feel like I've been taking over the discussion. You can go first, and then I'll give my take on this.
I think, like me personally, I enjoy doing research. I imagine, as long as I'm able to have a career doing research and, be successful and productive at it, I'll be happy. But I think like the big picture things, like there's huge racial disparities in terms of HIV and substance use, somewhat less distinct, but still, and disparities in terms of, sexual minorities. So I'd love to see progress being made in that area. And then, all of like the HIV field right now, like all of the work that we do is in the context of ending the HIV epidemic. Like there's real hope that with HIV prevention and treatment, medications and strategies that we can, get to the point where people are no longer getting infected with HIV, and the people who are living with HIV can lead long, fulfilling, healthy lives. So, to imagine that this like public health crisis that emerged in our lifetime could actually see an end, is, that's still a big, if, but, any work towards that and towards reducing the disparities, I think would be a big win. So that's what I'm invested in. And I hope that's what can happen.
And I guess for me, I love science. So anything that I can do to stay involved in the scientific field, agreed. Same as Justin. I would just want to keep doing the work. And I think it's so important. And I guess if I had all the time and all the money in the world, I would want to probably look at, continue working on the substance use field and how it intersects with people with HIV, and also helping to figure out how we can make better preventions as well, or organize better preventative measures. I guess, digging into my lab side, I really would love to look at the gut-brain axis and the gut-liver axis, and how, because my background mostly is in mucosal immunology and what happens in the gut during HIV infection, and how that can affect and we know that there's definitely a relationship between the gut and the brain and the gut and the liver, and how do all of those tissues work together and all of those different organs work together to make someone respond better or worse to different combinations of antiretrovirals or different substances, and how we can leverage that to improve human health, especially for people that are living with HIV.
Gut health is huge, isn't it? I mean, just as far as the proportion of our immune system that resides or is impacted by our gut health is tremendous, isn't it?
Oh, absolutely. It's the source of everything, and everything that happens in the gut can affect everything else. The bacteria that live in your gut, and the different communities that are there, can affect production of different metabolites and neurotransmitters, which can affect brain function. And your liver is basically a big filter and organ that can help you to maintain your health too. And so how does the gut and the liver are directly connected, and so how that interacts with each other, it just controls everything. And I'm a big fan of the gut. I have a pillow in the corner that's shaped like a gut, so it's my thing.
Great. Well, I've kind of dominated leading the chat with the two of you, but we want to open the floor to everybody. We know we've had some people patiently waiting to throw in some questions, I'm sure. So what do you all have? What questions do you have? Feel free to speak up.
I have a question, to
the
community, actually, if I'm allowed. I would love to. I asked Neil this question the other day, and I hope I've given him enough time to meditate on the answer. I would love to know, in the community, what research do you want us as scientists to do? Like, what would be the thing that you would like to most see us kind of take the direction of our research? That's my question. Cure, Michael. Yeah, absolutely. Oh, effects of cannabis on people in transition. Oh, that's very good. That's a fascinating topic. I would love to look at that too.
What else, folks?
Cannabis and immune modulation. Yes, that's a big one for me. I'm super interested in that.
And then terpenes, yeah, further breaking down the cannabis plant and how those individual terpenes may affect things. And Jamie with the second on trans people.
Oh. I'd be interested too, because given my love of co-infections as well, I'd be interested in, different herpes viruses and people with HIV and substance use. That would be a really cool study too. Or, just to understand. Also the hepatitis, all the, all of the viral hepatitis, that would be really interesting as well. I know there's some work with, I think, hep B, probably more hep C, but
So how about if I could ask, they have shingles vaccines available, I think in a 2 or 3 series shot. And that's something my dad gets, like a breakout on his head, and it's terribly painful. And so I went to go get my vaccine, and boy, it just made me really, really ill. If somebody with HIV, though, are they under, is it risky? Or obviously you consult with your doctor, but what kind of considerations does somebody with HIV have to make before getting some of these standard immunizations that are on the market?
Oh gosh. Okay, and full, disclosure up front, I'm not an MD, I'm not a medical doctor. So please consult with your actual physician before you make any medical decisions. I actually have no idea. That's a good question. I saw Michael put in here, means your immune response is good. I think it means that, it's doing its job. The whole idea behind vaccines and trying to boost immunity in that way is to teach your immune system how to respond to something. I mean, we know all of that now from having COVID and COVID vaccines and having that be widely available. But yes, the whole idea is that it teaches your immune system to recognize things and learn how to respond best to it. And so if you have an immune response to a vaccination, like a shingles vaccine, then I would hope that it means that your body is learning how to respond to it. And it means that your immune response has been initiated at the very least. And so if you ever were exposed to the viruses that cause shingles later, then, hopefully you would be protected.
Gotcha. We've gotten to hear from Dr. Fauci over the last 2 years on a pretty constant basis. Like, he's in our living rooms every week. And one of the things that seems he broken records with people is to remind them, look, research is not as fast as we want it to be. The data is not yet available. And so, yes, we see some of these indications, but we don't yet know. And it can be very frustrating to people who want answers, right? And understandably, what's something each of you wish the public knew a little bit more about what you do? Like when you give somebody a thumbnail sketch of what you do, is there a basic understanding that you wish more of the public shared, so that when you shared with them the research that you do, it made more sense, or you didn't have to cover that ground? Does that make sense?
Your question absolutely makes sense. I think that for me, what I would have said 2 years ago is I wish people understood how the immune system works. And then I could just tell them all the cool stuff that I'm doing. But I think that now that we've had COVID, everyone knows at least the basics. And I mean, silver lining, I guess, for COVID is that we've all gotten a very, very firsthand lesson in immunity and the immune system. And so for me, I love talking about my work, and I think that it means that, at least with COVID, it means that people have a better understanding of what I'm trying to do.
Thank you. Here in the chat, we see more comments about what people on the call would like to see researchers study more. So from Kim, cannabis hormones, specifically stages of menopause. Also puberty onset in young women. And then from Grandma Cat, the effect of full extract versus isolated cannabinoids, and the effect of cannabis suppositories on HIV patients, which is fascinating.
The full extract effects versus isolated cannabinoids is like something that I've been so curious about forever. I really, really would love to know that. And I think, for me, especially given my background in using animal models, specifically non-human primate research, I would love to try to do that. There's a wonderful person at Johns Hopkins who has been doing some really cool NHP work with cannabinoids. And so I'm hoping to work with her to do some fun new projects and figure out, questions exactly along that line. I think that that's a great topic. And also the women's health topics. like I said, my other science hat is looking at malaria and HIV co-infection specifically in the context of pregnancy. I really would love to merge the two eventually so that I can look at, take the substance use expertise that we have and the women's health and see how all of that would intersect with each other. So yeah, I think those are really important questions too. But that's, I'm rather biased.
So Jen, like for a non-lab person, right? Like when I think about cannabis use, measuring cannabis use, it's about asking people, right? Like when did you smoke? How often did you smoke? Or, whatever. Now it's changed, right? There's ingestibles and all these different things, right? So I don't know, like all this nuance of like what cannabinoids versus full effect. Can you explain?
So for me, when I think about that, maybe this is just my perspective as well, and please correct me in the chat if I'm wrong with what the intent of that comment was. But for me, when I think about it, when you say you were to consume cannabis, full cannabis, so like you have the plant and it's either smoked or it's in an edible of some kind, you have that those specific cannabis portions are being broken down into their different chemical components. And so all of those have been shown to potentially have some effect on the immune system, but some might have different immune effects than others. And so identifying how each different chemical component of cannabis is affecting the immune system and which ones we can target in order to make either better pharmaceutics in the future or to target on the immune side what's happening there so that we don't have to use different kinds of medication that's already available or make new ones, then that's to me what I think. And, on the line of, some of the work that you and I have been doing, yes, asking versus, when and whatnot, we can get at that by looking at the level of those metabolites in a person either with HIV or just, in a different context of study. But that's really important because if we can figure out how much is in a person's system at the time and what their immune response is at the exact same time as that, we can say, okay, dose effect, yes, no. And if so, how does that lead to different immune responses? That's where my head at.
Yes, because when you talk about like the assays and you're measuring these metabolites, right? Like there's THC metabolites, right? But there's also like CBD metabolites, right? We know there's differences between THC and CBD. So what exactly happens like when you get the results from those assays, like in terms of like actually analyzing it, like do you still just say like this is a heavy user versus not, or do you
actually, so that's some of the work that we did with Michael at the ACTU in Seattle. So that was a really awesome study because, like you said, most of the studies have based their findings off of self-report, and even the paper that you and I are working on right now is self-report. But that doesn't always mean everything that we think it does. And so what we did in our Seattle study was really cool because we actually measured those different metabolites. And yes, we looked at the levels of THC, Delta-9 THC, but that metabolite actually degrades quite quickly. So what we did was we used a different metabolite. It was carboxy THC, which is a really long chemical name that I can never remember. But essentially what we did was we were able to say, okay, this one has a longer half-life and it sticks around in your system. And there were other previous studies that suggested that could be used as a way to identify different levels of use. So we took that level and said, okay, people that have above this amount are heavy users and people that have below this amount are occasional users. And when we did that, we were able to tease apart the effects of heavy cannabis use versus moderate cannabis use. And we actually just published a very cool follow-up study looking at the pharmacokinetics of that and refining those measurements. And that work was also done with collaborators at the University of Washington in Seattle. And I don't even really quite understand what a lot of the math and the pharmacokinetics, that was our collaborators, they put a huge amount of work into that, but we think we've refined essentially the ways that we can identify based off of this objective measure of looking at the level of metabolites, defining which groups people would align best with. And then in that way, we can have a more nuanced understanding of the amount of cannabis versus the amount of different metabolites and how that affects other outcomes.
And thank you for having that focus. Like Dr. Knox, if you ask a patient, are you a heavy cannabis user? Somebody might say they are, but all they're taking is a THC-based gummy. So really, if cannabis is a gumbo, they're taking one element of over 100. So they're really not, which doesn't represent the plant at all, or only minutely. So, like you said, like you've both said, there's so much to dig into here. In the chat also, we had a couple things, the suggestion of cyclic vomiting syndrome versus cannabinoid hyperemesis syndrome. So we know some heavy users, have problems vomiting, and then, for some reason, hot showers help subside that feeling. But then when you back off, you stop feeling it, and that's only something in the last few years that the cannabis community has been aware of or widespread knowledgeable of. So, and then cannabis and gastroparesis from Jamie. Jamie, all kind of ideas. Michael as well. Thank you, both. So we are, here, one more question from Lauren. I have some anxiety and fear of the syndrome that causes vomiting. I think I read that it's also seen more in young males. And yeah, so we have so much more to learn. We do know, at least initially, it looks like if you back off your use and let your endocannabinoid system reset a little bit, the system or the syndrome seems to go away. So it seems to be within people's control to at least mitigate the effects of that. But that's still so new, and it's a kind of violent response from the body telling us something very important, I would imagine. So we want to thank you both for taking your time today. We know what you're each studying are really deep dives. So thanks for making it digestible for us and not leaving us in the dust, and doing a great job to explain what it is that you're passionate about and why we should care about that. And then also look into the future. We know, time is your most valuable resource. So we appreciate you spending your life's work on something that's very near and dear and affects people's lives every day. So we appreciate that. We appreciate you for mitigating the impact of this virus on people's lives, and then trying to also prevent more people from being exposed. Thank you for your work.
Thank you for having us. It's truly been a pleasure, and thanks for letting us share this space with you.
Absolutely.
Yeah, appreciate it.
And Neil and Full Spectrum, thank you so much for setting up this opportunity. We'll turn it back over to you.